This is Aging Forward, a podcast from Mayo Clinic about geriatric medicine and the science of healthy aging. Each episode, we explore new ways to take care of ourselves, our loved ones, and our community so we can all live longer, fuller lives. I'm Dr. Christina Chen, a geriatrician and internist at Mayo Clinic in Rochester, Minnesota. And this episode, we are talking about a guide to health screening and prevention throughout the aging journey. And our guest today is Dr. Danny Sanchez Pellecer, who is triple board certified in internal medicine, geriatrics, and palliative medicine. He is one of our staff members in the Department of Community Internal Medicine at Mayo Clinic in Rochester. So welcome and thanks for joining us today, Dr. Pellecer.
Thank you very much for having me. It's a pleasure being here.
So we always like to kind of start with the basics and just understanding basic terminology of preventive health versus health maintenance. What's the difference there?
There's really no difference between health maintenance and preventive health. I would say that we use these terms interchangeably. And at the end of the day, they basically lead to the same process. Just a group of different type of testings or interventions that are specifically designed to help prevent things before they happen or try to find things before they get too bad.
At a high level, what would you say are the general benefits to preventive health screening for older adults? What are we trying to prevent in that population?
Overall, I will say that the main objective of preventive health in older adults is improving their quality of life.
Yeah.
And at the same time, reduce cost, not just for patients themselves, but also for the healthcare system. Because I think preventing is going to be significantly cheaper than curing a disease.
So what we're saying is that they may have, say, hypertension, diabetes, or whatever XYZ health condition, but there's still a lot that can be done to prevent things such as hospitalizations or falls or worsening of a condition that could lead to those situations.
Yeah, that's right. I definitely see lower rates of hospitalizations, less healthcare expenditure when it comes to money. And usually when we catch cancer in patients that have their normal follow-ups, we usually catch it early, so it never gets that bad. And in fact, many times we can get patients in complete remission, meaning that we are able to cure them as long as we catch things on time.
I could see why in the younger adult population and average adult population, we want to get ahead of that as early as possible to prevent disease occurrence. How is that different for older adults who, say, have perhaps already developed a chronic disease? How does preventive health look different for them?
I would say that there's a lot of slowing down of the metabolism and slowing down of all the systems as we get older. So there's going to be a lot of chronic conditions that will probably not present until later in life. So usually we like to start around age 55 for certain things, age 65 in certain others. As an example, when we talk about weak bones or osteoporosis, that's not something we typically will see in someone young. That's something that it happens after our metabolism has slowed down and we're not producing as much bone density. And so therefore, that is more of a process or a screening that we worry about more in women once they reach 65 years of age.
You mentioned changes in metabolic health and bone health. Are there any other specific risk factors that make preventive health more crucial in the aging process?
I think the other big one will be the immune system. I think the immune system tends to slow down as well. And, the immune cells, it takes them longer to really try to alleviate any threats. So that makes older adults more vulnerable to infections. And at the same time, it is our immune system that tries to protect against abnormalities in your cell proliferation. So those slowing down of your immune system can also lead to development of cancers, which we also tend to see as we get older.
I often do see some people who come in their late 60s to 70s for the first time getting their preventive health screening. And by that time, they've developed a multitude of other health conditions. And I'm just wondering, have you noticed common barriers for older adults as they access early preventive health? Why do some of them get their cares too late?
There could be several reasons. And I would say here in the United States, healthcare has become very expensive. So lack of insurance coverage is probably a big one. Also, it is very well known that rural areas tend to have less access to healthcare in general, and then preventive health is no exception. And human nature tends to be more of a We don't like prevention very much. We're very good adapters. We adapt to crises very well, but we're not very good at preventing things.
Yeah, more reactive.
Right, right.
What about challenges across different demographic groups?
I think the cultural differences may actually impact how well received certain preventive services are. Certain communities, especially Indian American communities, they may have some mistrust in the medical community and they may not be as receptive to, for example, receiving a vaccine. And then, of course, here in Minnesota, and specifically in Rochester, we have our farming community where they've been working really hard their entire lives and they're very tough.
Right.
So they don't feel that they need certain things. They're also somewhat resistant to receive vaccinations or even do testing. And they always come with an attitude that, hey, if I'm going to get cancer, then that's fine. I'll get it. And again, a little bit back into that mentality of I'm going to react to a crisis when it happens. If the crisis hasn't happened, I don't need to worry about it.
Mm-hmm. Yeah, I think that's why it's important to explore the person's beliefs and values and whatever misinformation that they have heard or perceive on their own is to help educate them in that aspect of understanding that there are benefits.
Yeah. And in reality, there's no better way to do that than really establish a good relationship with each patient. And the only way to do that in modern medicine is to have patients come back at the very least on a yearly basis. Even if there's nothing wrong, everything is okay, but at least just to touch base, there's always something. And that's where we try to counsel patients in terms of what vaccinations, what testing would we recommend to initiate some preventive services and alleviate some of the mistrust that they may have or hesitations regarding testing or vaccinations. What can we do to revert those things?
Right. And you're always so good with having these conversations. I feel like you're the pro at that.
I try to, yes.
So what would you say would be the most important screenings older adults should be having on a regular basis to, again, prevent these things from happening and so that we're not so reactive?
I would probably focus on colonoscopies, mammograms, prostate cancer screening, and bone mineral densities. Now, how often? Depends on the result. I think the more straightforward is mammograms. Usually, PSTR recommends every 2 years. Here at Mayo Clinic, we actually recommend it yearly. I may space it out more in my older patients, as past 80, 85 years of age. If we decide that it's still okay to continue, I will probably space it every couple of years. With colonoscopies, it really depends. If the colonoscopy is completely normal and we didn't find anything, then it's 10 years. But then it may be 3 years, it may be 5, it may be 5 to 7, depending on how many polyps were found, how many were removed, and what did the pathology show. When it comes to bone mineral density, similarly, it depends on the results. If the bone mineral density is really bad, but not necessarily in the osteoporotic range, then we may want to repeat that in 3 years. However, if it's more in the mid-range, then we may wait a little bit longer. Usually, as a general rule, I don't like to wait more than 5 years to repeat it. There's some specific testing that is recommended in older adults that have certain risk factors, and I will say the biggest one is older adults that smoke. Another important screening test is an ultrasound of the big vessel aorta to make sure that there's no development of an aneurysm, right? And that one is important because if we don't catch that on time and an aneurysm bursts, there's really no time to treat that. And so patients can die very suddenly if that happens. And it's such an easy, cheap test. Our technology these days has gotten to a point where we can do this with relatively lower rates of side effects or complications.
So you mentioned colonoscopies, mammograms, prostate screening, bone density scans. And if you look at the USPSTF general guidelines, it mentions when to start. And then afterwards, it gets kind of muddy, right? After a certain age, it's like, oh, just talk to your doctor and see what's the best for you. But it doesn't really give us a lot of clear guidance about when to actually stop. So how do you approach that in the absence of official recommendations? When do you think is a good time to stop screening?
That's probably the question that got me very interested into this topic of prevention. And I would say that the decision to when to stop has to be an individual one. And age is only one thing to consider. There's many other components to be considered before we decide when to stop. apart from age, those things will include the patient's preference, the patient's family history, and I think most importantly, what is the life expectancy of a particular patient. And the reason that's important is because we have determined that certain screening tests will have a specific time period where we are going to observe a survival benefit. So I would say that if a patient is sick enough that their life expectancy is potentially less than 10 years, there could be more damage or more side effects if we do a specific screening test versus stopping. And to the contrary, if we think that there is the estimated life expectancy exceeds 10 years, I think there is significant benefit of continuing cancer screening. So my approach in clinic is have an honest discussion with the patient and see what is the patient's preference, use that as my guide on where to go next. And if the patient's preference is towards continuing screening, then I try to estimate the life expectancy. And we have different tools that we use to do that. And once I have that, then I put everything in a balance, have a discussion with the patient, and we together make the determination whether it's appropriate to stop or not. Unfortunately, there's no recipe, and that's probably why there's no guidelines, right? Because the topic is way more complicated and there's so many things that you have to take into account. And at the end of the day, the final decision is one that you're going to formulate after you have the honest conversation with your doctor.
Yeah, that's really helpful. I agree. I have so many patients who are in their late 80s to 90s who are just doing so great. They are living their best life. They're so functional. And it's like, well, I could see you living another 10 years into your hundreds. And you'd be surprised. A lot of times they'll tell you, like, I've gone through my screening. I just don't want to go through anymore. That's their decision.
And that's okay. And that's okay. And then I have had those situations as well where I see and I estimate their life expectancy and it's actually more than 10 years. And if their preference is still, no, I think I would like to stop, that's perfectly reasonable. As long as they have understood the rationale why we would still recommend to continue. And the other way around as well, right? Many times there's patients that are significantly sicker, they're in and out of the hospital, have 5 different chronic severe medical conditions, and they still want to continue doing colonoscopy, still want to continue doing mammograms. And in that case, I have to sit down with them and have that difficult conversation of disclosing, well, your life expectancy is probably not as high as we would hope. And that would potentially mean that if I continue doing colonoscopies in you, I may be hurting you more than helping you by continuing screening. You may have a very bad side effect from anesthesia, or you have a complication or a bowel perforation. And at the end of the day, if the patient decides, you know what, that's okay, that's a risk I'm willing to take, we always have to respect patients' wishes. And as long as it's within the appropriate risk, then many times I have ordered colonoscopies in these scenarios.
So let's move on to vaccines and immunizations. We've come a long way with vaccines and public health efforts, and it's saved a lot of lives over the years. And there's been a lot more vaccines that have been developed in recent decades. Which ones would you say are the most important for older adults?
Yeah, it's a very important topic. And going back to what we said at the beginning, when our immune system slows down, right? So that makes older adults more susceptible to severe infections. And one of the most common conditions that actually kill older adults is pneumonia. And I would say pneumonia is one of the vaccines that it's very important for older adults to receive. And pneumonia has different strains, and now each 5 years or so we have a new pneumonia vaccine that covers more strains, and we have a new one that came out 2 years ago. It's called PCV20, and that's the one currently being recommended in patients that are 65 years and older. The other big one, and the one that I think, if there are patients out there that are hesitant to receive it, I will ask them to just think twice, is the shingles vaccine. There's a relatively newer shingles vaccine version since 2017. The newer vaccine has a completely different mechanism, and not only has the advantage that we can use it in patients that are immunosuppressed, but the efficacy in the studies is significantly higher than the older vaccine. It reaches up to 80% in older patients. And I would say the most important thing of this new vaccine is that it is really good in preventing post-herpetic neuralgia, which is the pain that comes after getting shingles. And that pain, no one wants to get it. It's very difficult to treat. The medications available are not great for it, and it's very debilitating. And if we have something that would potentially help you prevent getting the pain, then that's great.
Yeah.
And then the third, a new vaccine for older adults is the RSV vaccine. RSV came out last year. We have two different types. Both seem pretty effective. One interesting fact about this vaccine is that as contrary to, for example, the flu and the COVID vaccine that we need to get every year because these are respiratory viruses, so far, one single shot has been enough at least for 3 years. That may change. The studies are ongoing, but it's another good vaccine to recommend and consider in patients older than 65. RSV virus is another big killer, and many times it can cause severe disease that can land patients in the hospital many times, or many times in the ICU.
Yeah. You're so right about the pneumonias because GI and respiratory tract are the main organ systems where we're constantly exposed to the outside environment. So
Right.
that's just the immune system, and these organs needs to be robust and
Right.
prepared to handle these situations. And so I'm glad you started with that understanding. And from my perspective, I had shingles. Even in my 40s, I had shingles.
Right, yeah,
It was like the most painful. In fact, I still have occasionally will have those post-traumatic neuralgia symptoms. So it's something that I always remind people. It's not just the event.
Infection
it's the
itself.
after effect that like stays with you.
Yes.
So.
And many times I get questions from patients, oh, I already got shingles, so I don't need to be vaccinated. And there's actually a lot of benefit from getting vaccinated, even if you had shingles in the past. And again, each time that you get vaccinated, you get better protection, particularly against that pain that comes afterwards.
Right.
Another thing to consider is that different than several other vaccines, the new shingles vaccine is a series of 2 shots that comes, and then you should receive it 2 months apart usually. Another big question that I get when it comes to shingles vaccine is, I just got shingles, so when can or should I get my vaccine? And usually I think that time frame is 2 to 3 months is what most experts recommend.
So there are 4 million older adults who are considered completely homebound or mostly homebound, meaning that they can't leave their home without extreme effort or needing assistance. How do we improve vaccine access to people who are in that situation or in more rural areas where they may not have access to healthcare services?
I don't think there's a right answer to that. I think that we need to make better efforts at trying to cover this vulnerable population. And I think, we have a homebound program to get vaccinations to these vulnerable patients. However, the program we have here is not necessarily something that has been replicable in other parts of the country. I think at this point, we need funding and initiatives to help these programs grow in different communities, because it needs to be a more sophisticated system that is well thought of. And to do that, what you need is money, and you need staff too, right? Because administering a vaccine, you need someone that is trained to do it. So it's definitely a very complicated problem that does not have an easy solution.
I wish they had like a mobile vaccine clinic or something.
Yes.
Maybe they have that already. I'll have to look into that.
New York City actually has one. Usually they go neighborhood to neighborhood. And even though it brings the research closer to different communities, my understanding is that the staff there does not necessarily go to patients' homes, which is ultimately what we would need to deliver this service. But yeah, I think it will be a very nice problem to tackle.
Yeah. I think we should just rent a van and grab some volunteers, get some extra vaccines and just drive around Rochester and get it to people who need them.
I can tell you what will happen in my home country, Guatemala. They will use medical students to do this.
Oh, yeah. We've got medical students who would be willing to do that for sure. Let's move on to some things that we often don't think about. Screening our cognitive and brain health and sort of our functional health. I feel like that's not often seen as routine preventive health in the average adult population. Can you speak to that a little bit?
I think the barrier or the challenge that we've seen and why this is not more widely done is probably because if you look at the USPSTF guidelines, they themselves actually recommend against routine screening for cognitive disorders. And I think the main reason for that, or the main reason we haven't observed a benefit in studies, is because we don't have treatments, or we don't have good treatments at least. So there's no good cost benefit, I guess, that the USPSTF has observed. What they're recommending is perhaps it's better that you spend your time trying to counsel patients on vaccines and doing colonoscopies and mammograms, because then we can actually have something solid to build outcomes on. And the reality is that screening for cognitive impairment definitely takes time. With that being said, the fact that we don't have good treatments doesn't mean that we shouldn't be looking for this, detecting it, diagnosing it, because there's other things that we can do, like counseling family members or pair patients and families with resources in the community that can potentially improve the patient's quality of life. So what I always do is once every other year, I like my patients to come with their significant other, because the significant other can tell you immediately whether something's wrong or not. And there's certain screening tests where you can have 2-3 questions that are very quick that our nursing team can do when patients are being groomed. I will say that cognitive assessment or screening is particularly important in patients, older patients that start struggling with falls. I think that may be the initial presentation of a cognitive problem. So as a routine, any patient that starts falling, they use that as an excuse. You know what? I'm going to make sure your memory is doing okay. And in a busy primary care practice, you may actually need to bring the patient back specifically to do that. But I think that's usually the approach that I take.
You're right. I feel like that's such a big gap that's missing, because the reality is a third of us, if we make it to age 85, will have some form of dementia. And that dementia screening is just, you're right, it's hard to do, it's time consuming. And what's the treatment? What's the course? So I just feel like we need to flip the script there to understand that even early detection and prevention of cognitive impairment, it pays dividends later on. Like there's long-term benefit where our goal is to keep them functional, keep them from falling, keep them from having dementia-related behavior issues that will end up in a bad outcome. Do you feel like it's important to also weave in that functional assessment too? Because you mentioned like the fall aspect. How do you assess one's function and their ability to stay independent in there?
Yeah, basically at least once a year, all my patients 65 and older, I like to do a balance test in office. And depending on the results, that can help you counsel patients in whether they need a gait aid, for example, a walker or a cane, and it will definitely help you prevent falls. The other big thing that I tend to do is I measure the gait speed of patients. That I think that's very highly predictive of disability. If they're both bad, then I know that I need to worry and concentrate on perhaps doing some balance training, physical therapy, feeding patients for a gait aid. And that sometimes is challenging too, right? Because many of our older patients don't want to be on a gait aid. But doing the testing in clinic also helps a lot to show them that, like, this is why I'm worried. This is what puts you at risk of future injuries. And I definitely don't want to deal with a hip fracture. I'm sure you don't want to deal with that yourself. So I think those are the two main things that I focus on when I worry about mobility or functioning.
I feel like prevention really should be a day-to-day thing.
Right.
It shouldn't be like, prevention only happens when I see my doctor once every year or every other year, right? So what are just day-to-day health maintenance habits that older adults should be adopting as soon as possible?
I don't think those are particular for older adults. I think it's for all of us, and it's the common sense things like eating well, eating a healthy, balanced diet, exercising ideally every day. I always tell my older patients, you don't have to train for a marathon. Movement is life. So it's definitely exercise. Another big one that we rarely discuss is sleep habits. And I always recommend patients, you need to be able to sleep enough time. And I always say enough time, because sleeping 8 hours does not necessarily apply for every older adult, but sleep enough that to the point that you are rested and trying to reduce stress. So eating, exercise, resting, and sleeping well. Those are probably the main things.
Yeah, I feel like that's been a common theme that we've heard from all of our speakers on the podcast, is just the importance of all those healthy pillars to well-being.
The other thing that I commonly see and I counsel patients on is, let's try to quit smoking if you are. In alcohol consumption, maybe the other one. Try to limit alcohol intake as much as possible. I think those are other healthy habits that every older adult should incorporate.
So caregivers are unrecognized heroes in so many ways. We want to be able to help support and empower our caregivers who really are doing all the day-to-day. How can we help caregivers stay informed with preventive health practices and help their loved ones stay on task? What are some resources for them?
I think the USPSTF guidelines are the easiest to navigate. They're widely available online. They're free. It's very easy to access. And they're very straightforward. And they come with nice graphs and tables, very easy to understand. So that's probably what I would recommend.
And what has been your personal observations with health maintenance that has been delivered well and delivered effectively? Do you have any good outcomes or positive stories to share from your practice?
Oh, absolutely. Most breast cancers that I caught are so small and so early that my female patients don't even need to get a mastectomy to get it treated.
Yeah.
Usually they just get the tumor out, they get radiation, and that's it. They don't even need to get chemotherapy, and they're cured. I think I have probably a patient every month sharing a similar story related to that. The other thing that I've seen is patients that exercise, they do well in general. Rarely need to start an antihypertensive. Rarely I have to use a cholesterol medicine. So mobility, exercise, that's very important. My success stories are just basically keeping patients out of the hospital, healthier, with minimum amount of or no medications at all.
Mm-hmm. You should share your story about your dad, your father.
Sure. He is almost 80. He looks in excellent shape. And a few years back when we were celebrating his birthday, we went out to a lake and he does slalom water skiing. And he's really good at it, even better than me. And at his age, he's still able to really ski really well. I always say, if I manage to get all my patients by age 80 to still do slalom water skiing, then that will be a success.
My last question for you, this is the tradition we have on our podcast here, is we just want to get to know our expert and to learn a little bit about how you personally age well. What are things that you like to do? What does aging forward mean to you?
To answer that question, I'm going to tell you what I tell every medical student, fellow, or resident that works with me. After they complete their geriatric rotation, I say, well, if you learn only 2 things from this rotation, start eating well, take care of yourself, and save money, because getting old tends to be expensive.
So that's what you're doing right now?
Yes, trying to eat well, exercise regularly, and I'm starting to save money. Yes.
What kind of exercises do you like to do?
Running, and I used to do a lot of karate when I was young. So I do some of that on my own, but mostly running. And I love running in the cold. So in a way, I feel that I was meant to live in Minnesota.
Oh. This is a very helpful conversation, Dr. Sanchez. Thank you for summarizing things so well in a situation where there's just so much information out there between guideline recommendations and updates. It's just helpful to know what's the most important for each person, the individualized decision-making, and how to effectively use diagnostics in a way that really contributes to not just adding more life to years, but years to life.
Absolutely. Yeah, my pleasure. Thanks for having me.
So that's all for this episode. Hopefully you are feeling a little bit more informed, inspired, and empowered. And if you would like to explore the USPSTF guidelines Dr. Sanchez and I discussed throughout this episode, you can check out the show notes online. On the next episode of Aging Forward, hospital stays and how to return home safely.
How long do you think that patients are out of bed when they're in the hospital? In a typical 24-hour period, it's less than 1 hour.
If you have a topic suggestion for a future episode, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more Aging Forward episodes and resources, head to mayoclinic.org/agingforward. Thanks for listening, and until next time, stay curious and stay active.
If you're a podcast host, listen up, this one's for you. My name is Allie Jackson. I'm the host of Finding Mr. Height, a dating and relationship podcast that I've been doing for 4 years now, sharing my positive and practical approach to dating that's built on my own life experience. And I wanted to share another experience that I've had, my secret behind monetizing my show. It's called Red Circle, and I was just telling my colleague about how much I love their platform. With Red Circle, not only am I getting a seamless hosting experience, but I also love the support I receive in ad sales. It's not just typical ad sales either. It's targeted targeted opportunities based on my show and my life. And the platform is super simple. You just set your preferences and Red Circle matches you with sponsors that align with your show. You can vet every opportunity and their platform gives you great analytics. More recently too, my Red Circle team has brought me opportunities outside of my podcast on social media to really augment the podcast partnerships, bring them full circle. I just can't recommend them enough. If you want to give it a try, go to redcircle.com to get your free trial. That's redcircle.com for a free trial.